Hello everyone. In this video, I want to talk about pericarditis, and we're going to talk about pericarditis and pericardial effusion, as the two are quite commonly related. So, in order to talk about pericarditis and pericardial effusion, we need to have a better understanding of, well, what is the pericardium and what is the pericardial fluid. So the pericardium, as most of us know, is going to be the outer layer of the heart, or the tissues that surround the outer layer of the heart. Within the fibrous pericardium, or the outer layer of the pericardial sac, we have pericardial fluid. So what we're looking at here is this outer layer, or this outside layer of the pericardium, is the fibrous pericardium. And within the fibrous pericardium, we have our pericardial fluid. So what we're looking at, this light blue substance here, is pericardial fluid. So if we kind of blow this up, or we kind of take a more enhanced view of what we're looking at, obviously this inner layer of cells here is our myocardium. We're looking at the epicardium on this outer layer of cells. This fluid that's filling the pericardial sac here is our pericardial fluid. We have two layers of serous pericardium. So we have the inner layer here, and then we have the outer layer. So these are our serous pericardium. And then the outermost layer here is our fibrous pericardium. So obviously it's going to be more fibrous than our serous pericardium, and gives more integrity to the pericardial sac. So this is our fibrous pericardium. And the primary job of the pericardial sac is to decrease friction of the heart as it beats within the mediastinum. So we have a heart that lives in the mediastinum. We don't want it to rub against the other organs or the tissues that are present within the mediastinum. So the pericardium provides a fluid-filled sac that's going to decrease friction, or the heart can beat against very little friction on the outside of it. In terms of pericardial fluid, we're looking at about 25 to 50 milliliters of fluid filling the pericardial sac. So obviously this is not a ton of pericardial fluid, but it is enough in order to reduce that friction and allow the heart to perform its function. So when we're talking about pericarditis, or we're talking about illnesses that involve the pericardium, often we're talking about pericarditis and pericardial effusion, two things that can be well related to each other. So I just want to break that down quickly for us. If we're talking about pericarditis, pericarditis is inflammation, or it's swelling of the pericardium. So when we're looking at pericarditis, it is inflammation of the pericardium. So we're talking about the infiltration of inflammatory mediators. So if we draw those in green here, we have our little inflammatory mediators entering the fibrous pericardium. And with that, we're going to see inflammation and swelling. So that's what pericarditis is. It's inflammation of the pericardial sac itself. So our fibrous pericardium is primarily what we're talking about here. The other thing that can go along with pericarditis is a pericardial effusion. And a pericardial effusion is where we have an increase in fluid in the pericardial sac. So pericardial effusion is a result of an increased pericardial fluid. And we can start to see the signs and symptoms of pericarditis developing with as little as 50 milliliters extra, or we can start to see an effusion occurring with as little as 50 milliliters extra pericardial fluid. So we're looking at pericardial effusion. What we're talking about is an increase in fluid. Now, if you think about it, those two things often go hand in hand. As we get an infection, or we have an infiltration of inflammatory mediators, we start to have vasodilation, we have an increase in inflammatory mediators, we start to have an increase in this fluid production. So as a result, often when someone gets pericarditis, it can lead to a pericardial effusion. But it's important to remember that not every pericarditis has to lead to effusion. So we're thinking about it, what are the causes, or we're looking at the things that result in pericarditis or pericardial effusion. There's a few different things that can happen. Obviously, the first one that makes sense is infection, and pericarditis is usually caused by a viral infection. So viral infection can cause pericarditis. You can also see pericarditis in patients who are post-MI, and we call that Dressler syndrome. So Dressler syndrome or post-MI. And the problem with that is as someone has a myocardial infarction, we start to decrease blood flow to the area, we have cell death, and as those cells die, we have a release of inflammatory mediators, which can lead to inflammation of the pericardia. We can also see pericarditis developing in people who are on radiation or who have cancer. In rare occasions, you can see pericarditis associated with trauma. So, if someone has a myocardial contusion, as the damage is being repaired, they can end up with pericarditis. You can also see it in uremia, which is a condition that occurs in people with renal failure, and they can't get rid of a ton of their nitrogenous wastes, and as a result, uremia develops. And what happens when someone becomes uremic is we start to see an increase in thickness of the pericardial secretions, which leads to irritation. So a couple that I want to talk about is I want to go through kind of this viral infections. We'll look at viral infection and see what the causes or what's happening when I have a viral infection that can lead to pericarditis. So as we mentioned, what can happen is we have a virus that infiltrates. So we'll draw our virus in red here. So this virus maybe infiltrates our pericardium. And as a result, so this is our virus, we're going to have the recruitment of inflammatory mediators. So as those inflammatory mediators make their way to the pericardium, they're going to perform their function. And one of the functions is inflammation. So we have inflammatory mediators. And these inflammatory mediators are going to perform their function, which leads to things like an increase in vasodilation, an increase in vascular permeability, and it usually results in swelling of tissue and the formation of a pus. So what happens is that this pericardium begins to thicken. So we see this kind of the fibrous pericardial layer can thicken, and as it thickens, it becomes more swollen. So we have swelling of the fibrous pericardium. It can restrict movement of the heart within the pericardial sac. So we start to see an increase thickness and fibrosis of the pericardium, or the fibrous of the fibrous pericardium. So it becomes thicker and a little bit more stiff than it would normally be. And you can see how that would start to restrict movement. The other problem is we can start to see an increase in fluid production. So we can start to see an increase in fluid within the pericardial sac. So as a result of these inflammatory mediators, we start to see some damage to the pericardial sac, which leads to fibrosis. We see an increase in vascular permeability and vasodilation, which can lead to swelling and edema, and we see an increase in fluid production. So our fibrous pericardium gets thicker, our pericardial sac becomes filled with more fluid, and we can kind of start to recognize that these are going to have restrictive, or going to restrict the ability of the heart to contract as much. Another problem that we have, or that we talked about, is that we can see pericarditis developing post-MI or Dressler syndrome. So we know that what's happening in an MI is we have ischemia of our myocardial cells. So we have cells that are becoming destroyed, or they're not receiving enough oxygen. And as a result, those cells are dying. And as those cells die, they release metabolites and they trigger an inflammatory response. So as a result of cell death, we start to see the recruitment of inflammatory mediators into the myocardium and towards the heart, which can lead to further infiltration of the pericardium, and there's fibrous pericardium and an increase in pericardial fluid. So in both of these instances, so in viral infection and Dressler syndrome, the big problem is that we have this increase in inflammatory mediators, which is damaging the pericardium, or they're performing their function in the pericardium. So we know that we have some sort of risk factor. So we have a risk factor that's going to lead to pericarditis. This could be MI, this could be viral infection, could be radiation, uremia, trauma. But something generally is going to lead to the infiltration of inflammatory mediators. So we see an increase in inflammatory mediators. And obviously, we're talking specifically about an increased inflammatory mediators in the pericardial sac here, so in the fibrous pericardium and the pericardial fluid. So this increased inflammatory mediators causes a couple of things to happen. We start to see an increase in swelling and edema, and a lot of that is related to an increase in vascular permeability. So an increase in vascular permeability, we start to see an increase in vasodilation, which can lead to fluid shifting. And this fluid shifting can cause edema. So as a result, we're going to have swelling of our fibrous pericardium. Another thing is this increased inflammatory mediators can lead to an increase in fluid production. So we start to see increased fluid production, which is going to lead to increased fluid in the pericardial sac. So we have an increase in inflammatory mediators, which is increasing vascular permeability and vasodilation, leads to fluid shifting and edema, which primarily affects our fibrous pericardium. So the fibrous pericardium thickens and stiffens. We also have an increase in fluid production, which is going to lead to increased fluid in the pericardial sac, which can restrict movement of the ventricle. And finally, as we have some of our cells being destroyed and inflammatory mediators are impacting our cells, we see an increase in fibrosis, which leads to stiffening of the fibrous pericardium. So if we think about it, our three primary problems, or three things that are going on here that are impacting the ability of the heart to dilate and contract, is that we have swelling of the fibrous pericardium, which is going to restrict movement of the left ventricle. We have a stiffening of the fibrous pericardium, which is also going to restrict movement of the left ventricle. And then we have an increase in fluid within the pericardial sac, which can also impact the left ventricle's ability to perform its function. All right, so in order to get a better idea of how this actually progresses, I wanted to take a look at how we go from having a pericarditis to a pericarditis with a pericardial effusion, which can eventually lead to cardiac tamponade. So what we're looking at in this first picture here is a heart that has pericarditis. So compared to our normal heart, we see a thickening of the fibrous pericardium. We haven't seen a dramatic increase in the amount of pericardial fluid, but the fibrous pericardium has become more restrictive. So this progression usually starts out with a increase in or stiffening and swelling of the fibrous pericardium, which is what we're seeing here. So this is our fibrous pericardium here, and it's stiffer and more edematous than what we would normally see in the fibrous pericardium. As we move into the later stages of pericarditis, or if it's allowed to continue, what we start to see happening here is we have our stiffening and swelling of the fibrous pericardium, but we also see an increase in pericardial fluid. And this is the pericardial effusion. So in the second stage, we're seeing pericarditis with pericardial effusion. So pericarditis on its own was simply this swelling that we're talking about here, so the swelling and stiffening of the fibrous pericardium. As we move towards pericarditis with a pericardial effusion, we can obviously see we have this dramatic increase in pericardial fluid, or a pericardial sac is beginning to swell with fluid, and we remain with this swelling and stiffening of the fibrous pericardium. So if we don't fix the pericarditis early, it can lead to this effusion. Finally, the problem that can occur if the effusion and pericarditis is left untreated, or we're unable to treat it, is that we can see tamponade occurring. So we can see cardiac tamponade. And tamponade is when we have so much pressure, we see the increase in fluid within the pericardial sac, and the stiffening of the fibrous pericardium is actually pushing in on the heart. and we're restricting the ventricle's movement. So our ventricles now can't fill properly, and they can't eject blood, or they can't contract properly. And that is when we can end up with a cardiac tamponade. And it's this progression that can lead to a number of signs and symptoms that go along with that. So we'll kind of start with the pericarditis itself and move towards what we start to see with pericardial effusion and then pericardial tamponade. So due to the irritation of the fibrous pericardium and the restrictive function that this has, or pericarditis has, on the heart, one of the common symptoms that we have with pericarditis is a chest pain. And this chest pain is usually described as a sharp stabbing pain. So the patients usually describe a sharp stabbing chest pain. It's often in the center of their chest, or they usually localize it to the sternal area, so a sharp stabbing sternal chest pain. You're also going to find that these patients are going to have an increase in this pain as they're supine or semi-sitting. And what's happening here is, as gravity pushes down on the chest wall, it actually pushes in on the chest. So as the person is seated forward, or even pushing themselves forward in the tripod position, they're reducing the effects of gravity on the heart, or they're reducing the strain in which gravity is going to put onto the chest wall, which puts further pressure onto the heart. So these patients will generally have positional chest pain with it increasing while supine or semi-sitting. So positional pain, and again, that's often going to increase while supine or semi-sitting. And again, these patients are primarily going to want to sit upright if possible. As we kind of move on with this, we can also see a fever developing. So as we have the increase in inflammatory mediators, as we have inflammation and swelling, we know that fever often goes along with those inflammatory mediators. The patient will often have a persistent fever. And this may last longer than a few days, could last up to weeks or months, depending on how long it's going on for. So usually you see fever, and it generally is going to be low grade in nature. Now, as we begin to move on, or pericardial effusion begins to develop, the heart isn't necessarily tamponaded at this point, or the ventricles haven't, the function of the ventricles hasn't been completely impaired. But as we move towards cardiac tamponade, our symptoms, we can see a number of different symptoms developing as well. So with that pericardial effusion, or as the fluid begins to build up in the sac, as the heart beats, we can actually see it swing side to side, or it starts to swing side to side within the pericardial sac. And one of the things that can develop with that swinging side to side is cardiac alternans. So what we're seeing here is alternans. So if you look, each QRS complex, we see it gets bigger, smaller, bigger, smaller, bigger, smaller. And what's happening as the heart swings away from the lead that's looking at lead 2 here, looking at the ventricle, the QRS complex gets smaller, and as it swings back towards it, it gets larger. So we can see cardiac alternans on our lead 2, and that's actually showing you that we have the heart is swinging within the pericardial sac. So the heart swings back and forth within the pericardial sac. Instead of alternans, what you may end up seeing is just low voltage QRS complexes. So because we have fluid filling the sac, the fibrous pericardium has become thicker, more swollen. It may be harder to get the reading. So instead of seeing this alternans, you may just see very low voltage QRS complexes. So the voltage may not be particularly high. The other thing you might see on electrocardiogram with patients who have pericarditis is a global ST elevation. So when we're doing a 12 lead and we see global ST elevation, that's usually an indication of pericarditis. That's why it's important for when we have people complaining of chest pain and we're doing these 12 lead ECGs, we need to be aware of mimickers, because this patient would not actually be a STEMI candidate because we're seeing a false positive, or this patient has pericarditis that's causing this global ST elevation. And if you want to know more about the pathophysiology behind that, I'll put a link at the top of this video that explains why global ST elevation occurs in pericarditis. So again, if we look at all these leads here, we're having ST elevation in almost every one of our cardiac leads, which again isn't indicative of pericarditis. So finally, as this progresses further, we start to see the patient's signs and symptoms getting worse or the condition getting worse, it can lead to cardiac tamponade. And cardiac tamponade is generally follows a triad of symptoms called Beck's triad. And Beck's triad is made up of JVD, or jugular vein distension, muffled heart sounds, and hypotension. And if you think about it makes sense when we start talking about this condition getting to the point where we have extreme restriction of our ventricles. So if we draw in our left ventricle here, or our right ventricle and our left ventricle here, what's happening is due to this constriction, our right ventricle, the space within our right ventricle is impaired, or we're starting to have decreased space in the right ventricle. As a result, blood that is trying to return to the heart can't, or we don't have enough space for filling. So we have decreased filling space. And as we can't accept that blood that's coming into the right ventricle, or we can't accept that filling, what starts to happen is the pressure builds up behind the right ventricle. We know that our vena cava, or our jugular veins feed off of our vena cava, so as a result of this increased pressure behind the right ventricle, we start to see jugular vein distension. The other thing that happens is we get hypotension. So as we're pushing in the left ventricle, we start to see decreased filling of the left ventricle and decreased ability to contract. So as a result, we're not able to push as much blood out of the left ventricle. So our stroke volume and our preload are going to be reduced, and so is our cardiac output. So when we're looking at cardiac output equaling heart rate times stroke volume, the problem in severe tamponade is that this stroke volume is significantly impaired, so we see a dramatic reduction in our cardiac output. And finally, we see muffled heart sounds because as we put our stethoscope on the patient's chest, we're hearing the heart beating within a fluid-filled sac, which is going to make it much, much harder to hear.